In Photonics, you'll recognize where I'm standing. Hello from Frankfurt Messe, which will be the venue for the ECOC Conference 2024, and it's the 50th time that the European Conference on Optical Communications will be organized. Now, you may know that Optica is an official media partner with ECOC. We contribute to their events like the top conference in London, and they help to support our events around the world. And when it comes to the ECOC Conference 2024 in September, we have a lot planned for the more than 6,000 people and 300 companies, many of them Optica corporate members, expected to show up. Optica will contribute to the sessions, we will do the live interviews on the exhibition floor, and we will organize the annual Optica VIP ECOC reception for our corporate members. But it's going to be a little bit different this year, since we are at the financial capital of Europe, and many of our corporate members are looking for investment and investing opportunities. Let me show you the spectacular location we have found. I am at the Osten, next to the main river and in front of the European Central Bank, and this will be the location for the Optica Executive Reception at ECOC 2024 on September 23rd. I am in Montreal, Canada, and behind me is the CHUM Hospital, one of the most important hospitals in this country. This will be the host of the Optica MedTech Industry Summit next 8th of October. Do you know that it takes about 10 years to put photonic innovation into the medical market? Bringing technology to save lives in photonics is the biggest valley of death. How can we solve this? In our opinion, we need to create a forum of discussion between companies developing photonics technology, medical doctors, policymakers, and regulatory institutions. Let's do that at a different hospital every year, and let's start right now. On the 8th and 9th of October, the CHUM Hospital will host companies from all over the world at executive level discussing their photonics technology, the roadmap towards medical trials, and which companies can play a role to help them get there faster. See you in Montreal on the 8th of October. It's an incredibly busy week for Optica, and Tuesday, June 25, marks a very special online industry meeting. We want to discuss the role of photonics in helping a growing number of people surviving and recovering from cancer. As we live longer, the incidence of cancer is rising, particularly in developing countries. We all know someone who has been affected. However, early detection vastly improves the chances of long-term survival. Artificial intelligence has the potential to transform cancer screening. How? By improving accuracy, efficiency, and speed of diagnosis. It may also help to solve the growing shortage of qualified radiologists. Optica is responding to requests from several corporate members to exchange ideas, strategies, and technologies to accelerate the detection and treatment of cancers. I find it strange that I can use my phone to order something to be delivered anywhere on the planet, but there are still no consumer handheld medically certified devices to scan for lung, breast, or prostate cancer. Yet, personalized healthcare is shifting from clinic to the home. Our online meeting brings together some of the world's leading companies in early diagnosis and treatment. We will hear from Anna Nikiel, who leads Teledyne Healthcare's revolution in breast cancer screening.
Breast cancer is leading cancer in women, affecting 1 in 7. Every year, 2.2 million new cases are diagnosed. Incidence is rising, especially in the developing country. Join me on June 25th at the Optica Online Industrial Meeting, while I outline how Teledyne new technology will revolutionize breast cancer detection, impacting millions of the women worldwide.
Meanwhile, in Tampere, I recall my visit to Modulite, who have 14 years experience in building complete medical laser systems for oncology professionals. Inside their dedicated labs, they work with industry partners to use lasers to treat lung, prostate, brain, and spinal cancers.
This was built up recently, really to support our customers even further in the collaboration we do with them. On this side, we have a cell culture lab where we can have for example, different cancer cell lines. And what is special here that we are, of course, using it for ourselves for our biomedical research. But what is interesting here is that this system actually has also modulite laser in.
In our meeting, we'll hear from Henrika Taitinen to better understand the mixture of technologies used to find cause and cure. We also welcome meaningful contributions from Art and Glow Biosciences, Hubner Photonics, and Milan-based pioneers with their non-invasive brain measurement technology, plus input from the founder of Raven, Wavelength Electronics, Tech5, Alphanov, and Oklahoma State University. And our discussion starts right now, so let me hand you over to your Optica hosts, Helena and Puya.
Hello, everybody. Welcome to Optica online industry meetings. So this is another chapter for our global events to get together all the photonics community, and this time we are going to fight cancer. So yes, we are going to fight cancer. We are going to fight breast and prostate cancer. So we all know that cancer remains like one of the most leading causes of worldwide, and we need to figure it out. The community help diagnose.
Yeah, I think Helena is breaking up. It's so
treat and save lives. So follow us.
Yes. Priya, would you like to take over? Helena, I'm sorry, we can't hear you.
Yeah, hello everyone, welcome to this online industry meeting on cancer diagnostics. I will be hosting the event along with my colleague Helena. She is busy also in Switzerland, hosting another, working with another Optica event, so her connection is a little bit shaky, but I will try to run this event now. So the topic is cancer diagnostics, and we are very happy to have esteemed speakers in here. Without further ado, I would like to introduce our first speaker to the meeting, Jonathan Liu from University of Washington. Jonathan, please share the screen, and the floor is all yours.
Okay, great. Thanks very much. I'll dig right into it. I'm at the University of Washington in Seattle. I'm also a co-founder of Alpenglow Biosciences, which is in Seattle as well. Today, my talk will focus on my academic research. The company is certainly interested in developing clinical assays. The CEO is a pathologist that used to work in my lab, but right now they're providing 3D pathology services and also equipment, microscopy equipment, to researchers and pharma companies. So just a reminder of some of the limitations of standard slide-based pathology. Everyone knows this technology. It's destructive. You're cutting tissues into thin sections, mounting them on glass slides. Usually you're looking at 1% or less of a biopsy. For a surgical specimen, it's much less than 1%. So there's quite a bit of sampling limitation for this process. And fundamentally, you're looking at things in 2D, whereas biology obviously exists in 3D. Now, of course, now we have digital whole slide imaging, but that adds another step. We're not replacing any of these steps. We're adding another step that could add time and money to the process. So the vision is if we can fix tissues and clear them to make them transparent to light and label them with fluorescent analogs of some of these pathology stains or antibodies, and then if we can image it in a high throughput fashion, this will be completely non-destructive. We would maintain all of the tissue for downstream assays such as genomics or other omics. We would be able to image 100% of the biopsy in this example in 3D. And on top of that, our clearing approaches are quite simple. They're essentially a series of reagent exchanges, so that could be easily automated, no histotech needed, no sectioning, no grossing of these tissues. So that's an added advantage. The technology, well, before I get into that, one of the questions we often have is, what is the value of 3D over 2D, especially since pathologists right now live in a 2D world, for better or for worse. So for prostate cancer is one area that we've been working a lot on initially. And there, many people know that to grade the aggressiveness of the cancer, we're using this process that was developed by Don Gleason about 50 years ago. Gleason grading is based entirely on trying to interpret the glandular structures. These are convoluted branching tree networks like vessel networks. And these can be quite misleading on 2D sections. For example, there are fully formed glands that if you cut tangentially look like poorly formed glands, and that could be the difference between surgery or no surgery for a patient. Another example would be complex distributions of cells. The best example of that is the tumor immune microenvironment, where studies show that if we can quantify the relationships between tumor cells and immune cells, that can be predictive for patients, whether they will respond to immuno-oncology, such as checkpoint inhibitors and CAR T-cell therapies. But the challenge is these tumor immune microenvironments are highly heterogeneous. And so depending on where you look, you might see something different. And in particular, you often want to be on the peritumoral infiltrating edge of the tumor to see if the lymphocytes are able to get in. This differentiation between hot tumors and cold tumors can be very useful clinically. And finally, there are rare events like lymphovascular invasion, perineural invasion. These can affect treatments, but they're often not seen on 2D sections because we're looking at such a small amount of tissue. So here, the ability to image orders of magnitude more tissue non-destructively and to identify these rare events with AI could be very helpful. So I won't go into a lot of details. We essentially have a flatbed scanner for tissues, that's what we call it. All of the optics are underneath a modular sample holder. It could be as simple as a glass plate or a multi-well plate or a custom biopsy holder. It's a stage scan system, so we move the sample through the light sheet and we collect a volumetric brick of data. And if we scan adjacent bricks, we can image very large specimens over time. We've published on 4 generations of systems, different resolutions, and we've improved the ease of use of the systems. Our last 2 systems have been multi-resolutions. As you can imagine, the data set sizes and the imaging time scale to the 3rd power with 3D microscopy. So we have to be very judicious in the level of resolution, and having that multi-resolution system really helps. Here's just an example of what a prostate core biopsy might look like if we're going from one end to the other, slice by slice, so to speak. This is a 3D data set, so it's a continuous, non-destructive image of that biopsy. It's about 1 millimeter in diameter and about 1 to 2 centimeters typically in length, where we can mount all of the biopsies on a sample holder and image them one by one. We have a stain here that looks like H&E. This is a fluorescent analog of H&E where we can false color the images to look almost identical to what pathologists are used to seeing on glass slides. We can also segment out the glands. As we mentioned, the glands are the basis for Gleason grading to determine which patients need aggressive treatments. Here we're looking at the lumen spaces of the glands in red, the skeleton network that extends through the glands, and the yellow are the epithelial cell layers surrounding the glands. From here, we can pull out features that help us to classify which patients have aggressive versus non-aggressive cancer. We did a preliminary clinical study with 50 cases. Half of these patients had recurrence of their cancer within 5 years of surgery. Half of these patients did not. So that's our aggressive versus non-aggressive group. We obtained simulated biopsies from these prostatectomy specimens, stained it with our H&E analog, cleared the tissue, imaged it with 3D microscopy, segmented out the glands as was shown in the previous slide. And then we wanted to compare 3D glandular features, things like volume ratios and curvatures, versus 2D, analogous 2D features from a few different levels from the biopsy. And so we looked at analogous features. If we were looking at volume ratios in 3D, we would look at area ratios in 2D, 3D curvature versus 2D curvature. And we correlated these features with the 5-year recurrence outcomes of these patients. To make a long story short, we saw that with a collection of 3D parameters, we can perform the analogous 2D parameters in terms of predicting which patients have aggressive disease. This is a Kaplan-Meier analysis. Time 0 is the surgery date. And over the course of 5 or 6 years, if we try to predict which patients have aggressive disease using a 2D model, we don't see very good stratification. But with a 3D model, we see very good stratification between our high risk and low risk group. So far I've talked about this handcrafted approach where we first segment out the glands, extract intuitive features, and then classify. That's great for developing insights and being able to test certain hypotheses. The alternative, which is potentially much more powerful, is to extract deep learning features in an end-to-end manner. This is very powerful because it can extract sub-visual features, but they're not very intuitive. It's more of a black box method. And so we recently published on this last month with our collaborator, Faisal Mahmood at Harvard. This is just one example result that sort of summarizes the whole story. So if we try to predict which patients have aggressive cancer based on the Gleason grades provided by pathologists, we have pretty decent performance, an AUC of over 0.75. But if we apply 2D AI on a few sections within the biopsy, we get better performance. If we apply 2D AI to all of the levels within the biopsy, so level by level, we apply 2D AI, we get better performance. But the best performance is if we extract 3D features from the whole biopsy. So these are features that you could never extract from a 2D image. These are volumetric subvisual features. So that shows you step by step the advantage of both looking at more volume of tissue, but also being able to extract those 3D deep learning features. So with that, let me just end by reminding us of one of our potential customers, which are oncologists, in this case, urologists. For other applications, it could be gastroenterologists. One of our competitors would be these genomics assays. There's at least 3 out there for prostate cancer that are used right now. These are destructive. For example, Decipher takes about a half a biopsy worth of material that has to be digested and destroyed to run a Decipher assay. They're also very expensive, $3,000 to $5,000 per assay, per biopsy. Computational 3D pathology, completely non-destructive. We can return the tissue to the archives as a FFPE block. No destruction of the tissue, no destruction of the DNA or RNA. And it's potentially very inexpensive. Because it's non-destructive, we can do all these things in a fully automated fashion. And so there are some advantages we hope that this can bring. So let me just acknowledge my team, various collaborators and funding sources. And with that, I'll stop.
Thank you so much, Jonathan. This is actually very, 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 very nice because I mean, having just dismissed the size of the biopsy, this is a big step. It's really, really a big step. And the other thing is like if you can actually diagnose this pretty quick, like what is the stage, what kind of cancer, what it could be the solution. So that's something that is really good. So the first question is, what is your major challenge to get this working in commercialization?
Yeah, so I think the major challenge is
Jonathan,
other than, sorry, can you hear me?
Yeah.
Yeah, so the major challenge is really trying to do
Yes.
the large-scale clinical studies to prove out the value. Right now, as I mentioned, it's a very preliminary study with 50 cases. Ideally, we need to do some prospective studies with hundreds, if not thousands of cases, provide the evidence, and to develop the computational pipeline that can really be reliable. And so that's really work that we're doing now with NIH funding, and hopefully, I know the company has aspirations to move towards clinical assays and raising funds to put together large clinical trials, for example, would be the next step.
Okay, thank you, Jonathan. We have a question here from Nathan Stibbins from Take 5 USA. Nathan, why don't you unmute yourself and put your camera on and ask your question so that everyone can see you?
Hey, Jonathan, great presentation. Just curious, how long does it take once you have a biopsy in hand for sample preparation and then the actual measurement itself? How long does that take?
So we've actually published a paper called 1 Hour to Diagnosis, where we can get freshly excised biopsies and within 1 hour turn things around into a 3D data set. That's not looking through the entire biopsy. If we want to have 1 millimeter of depth, that usually takes a few hours. In our lab, we don't do it that quickly because there's no reason to. We usually do it overnight, 1 or 2 days. There's no reason why we can't do it within a few hours. These stains are small molecules. They penetrate very quickly into 3D tissues. Unlike antibodies, if you want to do antibody labeling, that would take many days because they're large macromolecules that diffuse very slowly. But everything we have in our standard H&E analog process and clearing really can be done quite well within hours, I would say.
Great,
So
thank you.
what is the diff of the tissue that you can analyze actually?
Yeah, with a standard fast clearing approach, which is basically an iDisco clearing approach with ethyl cinnamate clearing at the end, we can typically image 0.5 millimeter, no problem with most tissues, up to maybe 1 millimeter or more. Depends on the tissue type. Mouse brains, for example, we can image through 1 centimeter. The whole mouse brain can be imaged with various clearing protocols. Clinically, we find that we don't usually need more than about 0.5 millimeter of depth to get good 3D information. That's already, in terms of raw data, it could be 100 gigabytes of data. So you don't really want more than that. And that's where our multi-resolution workflows come into play, where if we really want to image large volumes, we would do that at low resolution, ideally use AI to find the regions of interest to zoom in on, just like how a pathologist views glass slides. And so we're working through a lot of these different workflows to keep things efficient computationally and in terms of hard drive space and time.
All right, so we have another question here from David Goldberger.
Yeah, excellent.
David, do you have? Could you please unmute yourself and ask the question so that everyone can hear you if you can hear us?
Hey there, great talk. I was just wondering about how general the sample clearing process is.
Yeah, it works quite well. Our standard method, we just published the full protocol if you're interested in Nature Protocols a few months back this year. So you can have a look at that. Prostate, breast, where we're looking at esophagus tissues, Barrett's esophagus. So a variety of tissues, they work fine. There are some tissues that are a little more challenging. For example, human lymph nodes, we've had a little bit of trouble with. And there we use a different clearing approach called cubic. So there's probably not one clearing approach that will work universally for all tissues. People also clear bone. You can decalcify bone and image through bone. Those are more advanced clearing approaches. And so there's literally hundreds of protocols out there. Most people use a handful that are quite nice. But we found that, it's fairly general for most tissues, our standard cinnamon oil, ethyl cinnamate clearing approach. But there are exceptions, of course.
Thanks.
All right, thank you. And actually, we have another question coming from Francesca from AlphaNova. Francesca, would you please unmute yourself and ask the question? And I understand you also have one slide to present. So let's ask your question, and then after that, let us know about your watching.
It's an exchange. So hi, I'm Francesca from AlphaNova. Maybe I lost this information. You are talking about multi-resolution, low, high resolution, but actually I didn't understand what is the resolution.
Yeah. Sorry, for the sake of time, I didn't get into it, but on the high end right now, it's about 450 nanometers is the highest we've gone. We're building a system to go higher than that right now, but in terms of the published systems, it's about 0.5 micron. And on the low resolution side, that can be as low as 5 to 10 microns, sort of mesoscopic if you want. Right now, our systems are set for 2 micron resolution on the low end and 0.5 micron or between 0.5 micron and 1 micron on the high end.
Thanks.
And Francesca, you had one slide to present. Would you mind sharing that so that we know and let us know what you do and how we can help you?
You see the presentation, it's okay? Okay.
Yes, all clear.
Perfect. So I'm Francesca again from Alpano, and I'm working on the X-Pulse project. The aim of the project is the development of an imaging system for early breast cancer detection. X-Pulse is a collaborative project. Here you can see a logo from partners that are working all together. And this project is funded by Europe and Nouvelle-Aquitaine region. This system that is here depicted is based on breast CT and also on phase contrast imaging modalities that is a bit different with respect to what we have now in medical application that is based on absorption regime. To obtain these two features, we have to install on our system a particular micro-focus X-ray source that in this case is generated by laser. Here, this is our conversion system, and this is actually what happened. We have an high energy and pulsed laser that is focused on a conversion target that generally is made of metal, and then the plasma that is created around the metal can create an X-ray source. And this source has the characteristic that we are looking for, that is a micro-focus source with a high brightness. And, oops. And we know that the power of the X-ray source is increased proportional to the average power, the peak power of the laser that is implemented in the conversion system. So why we have also tailoring the characteristic of the laser. We have already validated our system with two lasers provided by Amplitude in France. And we took a full tomographic data set of 300 projection. This is a walnut, but in principle we can do with everything. And we prove that even changing the frequency of the laser, passing from 100 hertz to 1 kilohertz, we can reduce drastically of one factor the time of the exposure time, the total exposure time. And we are now commissioning an high power laser in order to collect a tomographic data set in few minutes. And according to our roadmap, we are developing with Amplitude our RD laser that will be a high power and high energy laser, let's say around always with a frequency of 1 kilohertz. And in this way, we will be compatible with a typical clinical examen for X-ray radiography. This is the six.
All right. Wonderful. That was your last slide, I guess, right?
Yes.
Okay. So
yes,
let me ask you this.
I put only two. Yes.
Let me ask you this question then. I mean, at these industry meetings, we like to put people together and have them collaborate. Yeah. So let me ask you this: how can we help you, and how can you help others? What is it that you're looking for that people can help you with?
So according to our project now, we have a collaboration. So we are working directly with Amplitude in order to achieve the characteristic of the laser that will be implemented in our CT scan for breast cancer. So this is the roadmap of the project, but let's say in a future for a commercialization of the prototype that you can see here in the picture, that is a conversion system that can create a microfocus X-ray source that can be used for any kind of radiographic application. Now we are talking about breast cancer. So the laser that we are looking for has precise features. But let's imagine if you want to change and go from breast cancer to another kind of cancer or another kind of illness, maybe we can tailor in another way the laser, and amplitude could be not the direct choice, let's say like this.
Okay.
And also
Wonderful.
concerning the implementation of the system, we have a detection system in order to collect images. Now we are working with a photon counting detector, but in a future for other application, maybe this detector is not anymore useful, and we can even move to another kind of detector. So this is what so why I'm here actually, to exchange with people that are used to work in the medical industry.
Understood. And actually, at Optica, there are many corporate members that provide
Exactly.
the laser solutions as well as
Yeah.
the detector solutions. And just I would like to remind everyone that if you want to get connected to Francesca, if you think that you have a solution for her, feel free to reach out to me or Helena and Jose, and we would connect you and let you guys have the conversation, and we make the handshake happen for you. Actually, we have a question that's come for you from Anna from Teledyne. Anna, why don't you unmute yourself and ask a question?
Yes. Hi, Francesca. Very nice
Hi,
presentation.
Anna.
I have a question regarding because CT, we know that the future of CT will be going in the photon counting detectors. Do you have already in mind the specification for your dream photon counting detectors?
We are participating in an R&D project. So it means that we have already more or less decided what kind of feature the detector has to be in order to have also to reach the spatial resolution that we want to have. In this configuration, let's say that we have the pixel size, for example, of the detector can stay in a range of 30 to 100 micrometer. And due to the fact that we are using this kind of source that is generated by laser, we cannot cut the X-ray spectrum at a certain point as an X-ray tube, because we don't have an high voltage system. So you have all the high energy that in principle could be a problem for other kind of technologies for detection, because, for example, in the case of a Teledyne detector that is implemented in a lot of radiographic system for breast cancer in particular, I know the high energy can be detrimental for the layer.
Yeah.
Yeah.
Okay, but we can take this offline, maybe.
Yes, of course. Yes, of course.
Very good. Thank you.
Thank you to you.
Oh, it seems the questions are flowing in. Let's take this one from Henny from Modulite. Henny, why don't you unmute yourself and ask the question?
Yes, thank you. I'm Henny from Modulite, and thank you, Francesca, for bringing this interesting topic to discussion. So I was wondering, do you have ideal parameters for a laser, or have you experienced any challenges with finding an optimal laser for this solution?
Yes, exactly. This is what I was trying to do in this slide, actually. We have to validate our conversion system. And today, we don't have on the shelf the good laser system. This is clear. So we started with something that is not very high in power. But it's only to see that with our system, we can create the X-ray source with a microfocus size. This is the first. Then we know actually the point is that one, we have to be close, we have to compatible with the clinical exams. So if you use the Magma 25 for amplitude, for example, this one at 1 kilohertz, then the exposure time for a tomographic data set of 300 projection is around 10 minutes, maybe more if you count. Maybe there are some problems, something to adjust in the system. And it is not what the radiologic unit in the hospital wants to have. It's very too long. So why now we are commissioning the other system at 80 watts, always 1 kilohertz. and we made some simulation. It seems that the total exposure time for the same kind of tomographic set can go down to 2 minutes, but it's still too long. And the final step is that one. So the laser that will be produced at the end of our RD project is very challenging, let's say, because the energy is very high. The repetition rate is also high. So the frequency is 1 kilohertz. If you want to stay in the regime of picoseconds, or we can go up if you change to femtosecond, for example. So let's say this at the end one, the last column is the dream. But we know that in the very near future we can go here already. And actually we are working on the commissioning, and we have to install this laser on our setup. But yes, this is our dream. Even more. I don't know if it's possible.
Okay.
But it's quite achievable, because I mean there are a lot of suppliers here. I mean, Modulite, we have like so many people here that can help you. I mean, Amplitude, they are also very good. They already work with you. So we have Michela Ceresa from Pioneer. So he wants to ask a question or make a comment. Please, yourself.
Hi, Elena.
Hi.
Thank you, and thank you, Francesco, for your presentation. So I was wondering if you have already in mind in the project a validation, the clinical validation, and what will be the step? What will the step be to reach the consensus on the usage of this kind of device? And if you already have partners around, and how will you tackle this kind of
Yes.
issue?
Yeah, it's a big issue actually, because if you want to put an imaging system in a prototype, because today is a prototype. So if you want to put it in a radiological unit of an hospital, you have to pass through a very long pathway, because first you have to do the validation using what is called phantoms. You find what is more close to the breast with some feature inside, and they can simulate the presence of a cancer, for example. This is the first step. Then you can calibrate with this phantom the dose that you give to the breast for the imaging, for, let's say, for the high resolution imaging. And then you can go to a step forward, and there is what is called a preclinical application, so imaging on animals. And then you can start, if this is good, you can start with the first trial on humans. It's very long. I think it's around 10 years or more, let's say. And in our project, we have a partner that is this one. Bergonier is well known actually in France, because they are working a lot on breast cancer, and they actually supporting us in the evaluation of imaging, in the performances of our system. And we are also going, for example, through something that is intermediate, because we are working on biopsy to see biopsies that are already tested and analyzed in the hospital. We can take it, and we can tailor our resolution to see what we want to see. For example, microcalcification. So this is the idea. It's very long. We have this partner that is very important for us, because we don't have all the knowledge concerning the breast cancer from a medical point of view. Let's say what we can do, it's also imaging. I don't know if I answered to the. It was a bit
Totally. Thank you. Yeah, I have another very small question, if I can ask quickly. Yes. I was wondering about the compression of the breast. If you still have to compress it, if the compression is okay.
Actually, there is no compression. So the idea is why it's a bit complicated. I was not able to put everything in 2 slides. I'm sorry, but yes, there is no compression. And why there is no compression? First of all, because it's a bit uncomfortable. Let's say for women. This is the first. And the second one is the fact that we want to use this kind of imaging modality that is called phase contrast. What is phase contrast? Actually, we can move from absorption that is known, I suppose, from everyone, and we can go to the, actually, we want to collect on the image the refraction of the X-rays. And the fact that we can collect the angle of refraction, we are sensitive to the angle of refraction. We can even do some chemical mapping on our X-ray reconstructed volume, let's say, because we know that the diffraction depends on the material. So in this way, we can do it's not, I would say it's not a quantitative map, chemical map, but maybe a qualitative, let's say. So you can separate different components, and the challenge will be actually go from qualitative to quantitative. And to exactly so, and another point is that to do phase contrast, we have phase contrast X-ray imaging. We have to change the energy of the X-rays. So today, to do absorption, we have to stay around in between 30, 40 maximum kilovolts for a tube, let's say. But in the case of phase contrast, we have to put higher the energy, and for higher energy there is no absorption for the breast because all components are absorbing in the same wave. So the image is plain, let's say. There is no contrast. There is no contrast in the image. I think that that's it. No.
Yeah, thank you so much. So someone that can help you with the laser, as I say, I mean, here is Modulite also, but we also have Hakan Carson from Horner Photonics. Hakan, how you can help Jonathan? How you can help Francesca, and tell us a little bit about all the technology that you are using, because all the lasers that you are having for medical application. So Francesca, would you please stop? Thank you.
I did it.
Yeah. So Hakan, yeah, let's welcome Hakan from Hopner Photonics, so corporate member. Yeah, can you please show your slide and tell us how you can help to all of us, and what also do you need from the people here in the room?
You see my screen now?
Yes, it's not on full screen, but yeah.
All right.
Perfect. Crystal clear.
Thank you very much. My name is Håkan Karlsson. I'm from Hybner Photonics. We're a laser manufacturer based in Sweden and Germany. We make several types of lasers, both in the CW and pulsed, tunable and fixed wavelength. Unfortunately, we're not very good in picosecond regime, so I don't have any immediate answer from Francesco. Unfortunately, today here I will very briefly introduce you to how one of our lasers is a short femtosecond laser, fiber-based, and I will talk briefly about how this is being used to enable what we call instant pathology using label-free nonlinear imaging. So we have recently been started to work with a company in Amsterdam called Flash Pathology. I'm afraid the logo is maybe behind the bars here, but it's behind here. It depends on where you have your videos. They have started to use this short femtosecond fiber laser into their microscopes and shown that these ultra-fast lasers can enable, by using nonlinear and multiphoton microscopy, do instant biopsy assessment and diagnostic that we think has the potential of replacing conventional cancer histology, because it can avoid any kind of staining or fixation or slicing of the biopsies, and thereby this technique can drastically reduce the wait time and then the risk for the patients, and also provide cost savings for the hospitals. And how this works is, the trick is to use a very short pulsed laser source, because these short pulses it means that the output power is coming in very high peak powers.
And these high peak powers then can trigger or onset several types of nonlinear processes in the sample, both multi-photon absorption, but also frequency doubling and frequency tripling in different types of biological structures. And in this way, it's possible to do interesting imaging of these samples without doing any labeling. And as the peak powers are very high, it's also possible to have very strong signals without applying a lot of average power to the sample, which means that samples survive for a long time, which makes it possible to study also how the samples react to different types of potential treatment drugs. And as this is a very nonlinear effect, the signals are only coming from the focus of the laser beam, which means that the system provides an automatic or natural optical sectioning. So it's easy to scan through the sample by the sample is still completely intact and build up 3D images. And again, completely non-destructive and free of any staining and fixation. So Flash Pathology has built a microscope where they integrate this femtosecond fiber laser, which is scanning across the sample. And then they collect multiple signals through up to 4 different channels from frequency doubling, frequency tripling, 2-photon and 3-photon signal responses from the sample. And in this way, they can then provide images with high resolution, both in 2D and also in 3D, which can distinguish quite a lot between microbiological compounds and structures that can be used for pathology. And this whole process takes a few minutes. They have shown videos where they take actually a researcher or a clinician takes a sample, puts it on the sample or on the sample holder, and 2-3 minutes after they have a picture they can assess. So they have made systems that are already out in hospitals being used for various types of clinical trials. And here are some examples. So this shows 3D image of biopsy from a lung, where then it's possible to see 3D. It's also non-collapsed lung tissue, where you can see the air bubbles in green still there. Normally, the biopsies from lungs are collapsed, like in this picture, which is also then imaged by Flash Pathology, where you see the epithelium in green and collapsed alveolar tissue on the right-hand side. Another example is up here. This is a biopsy from an actual lung cancer patient, where it's possible to do the diagnosis of lung cancer. It's possible to see the different types of cells and the abnormal cell division and multi-nuclei presence. And here's a final example from a healthy kidney with a typical tubular structure. And also here it's possible to, if you zoom in, to see the individual cells and the cell nuclei. And they become very colorful in contrast to the traditional H&E pictures because they have this multi-channel detection system. That's what I had to present.
Excellent. Thank you so much, Heiken. So this is one of the things, and this is something that is always amazing about the spectroscopic techniques. Is like it is possible to just translate for different biomarkers. So and also, I mean, it's not straightforward because you have different tissues, different characteristics or everything, but translating from biomarkers to others, so somehow you can translate the technology. So I would like to ask Jonathan, what do you think? I mean, so is this kind of things that is going to help you? Because this is a little bit kind of on the same page. So Jonathan?
Yeah, we don't use pulse lasers right now, but we do have some interest in nonlinear light sheet microscopy where this could be helpful. We do use these lasers. We use the cobalt, multi-channel laser right now, in our systems. So these are CW, lower power lasers. But it's nice to see a palette of different technologies, and pulse lasers could offer some advantages for light sheet, especially if we want to image into non-cleared sort of fresh tissues, where having the nonlinear effect could help us to get more penetration depth in these scattering tissues.
Yeah, I mean,
Excellent. Yeah, thank you so much. Yeah, go. Sorry.
The key thing with flash pathologist technology is the fact that they're using this pulse laser, which has a uniquely short pulse length. I mean, there is femtosecond lasers are not unique in themselves, but there are not so many of them that are emitting less than 50 femtoseconds, and then you get so high peak power, so you onset a number of interesting nonlinear effects into the biological samples, which seem to be very, of course, you cannot reach the same level of molecular specificity that you would do with labeled samples. But it seems like you can see a lot of interesting structures without labeling.
And good features too. So yeah, so thank you so much to all of you. And now let's move. So let me introduce. This is my big honor to introduce Professor Dakin Piao from Oklahoma State University. He's at the School of Electrical and Computational Engineering. And Dakin, the floor is all yours. Dakin?
Yes. Okay. Can you hear me?
Yes.
Okay.
Now I can hear you perfectly clear.
Okay, great. Thank you very much, and it's my great pleasure to be here. And then, I would like to thank particularly Dr. Jonathan Liu for introducing some very important concepts or the clinical the issues related to prostate cancer. And Dr. Liu's works are most recent. Our works might be slightly outdated, but the issues, the challenges, they all are still right now. And then the lessons we learned may still be new. And so we need more attention to this. So my brief presentation will be on our works that using just light, try to probe the prostate. And as Dr. Liu mentioned, there is a hot and cold their prostate cancers. So their pathology side would be after taking the biopsy, but before taking the biopsy, and then where to go. So that is still a question. So, and then this work, I hope that I did not forget any of the collaborators. So I had a few major collaborators in our vet med college. And by the way, Dr. Bartels, he is an Army colonel. And I also had here are my colleagues, and also have my clinical collaborators and also other colleagues, and we collaborated over different projects. And also I'm fortunate to have one of my students right now is an assistant professor in University of Michigan Medical School, and he is continuing on using photoacoustic technique for prostate cancer research, and they have recently done one study with a human subject, so that was very exciting. And I'd like to acknowledge some earlier funding support for me and some other collaborations that we have been going. And by the way, I have a Korean ancestry, so sometimes you might find me disgrace myself with this name on some kind of social media. And this audiences or this floor, we all know about these cancer statistics. This might be a little bit old, but the problem is it sustains. So prostate cancer for men is still the highest occurring cancer, and then the death is still very high. So there is a need to find it, to treat it. So in terms of the clinical flow, I think the problem has always been for prostate cancer. Some patient might be referred for some kind of biopsy due to screening due to maybe some clinical symptoms. And then in the end, the problem is that we need to find where is the cancer. And then we need to know if the cancer is hot or cold. And if cold, you might leave it there, and then for many years, not a problem, but we really need to find the hot one. And also when you have many different ways to do it, maybe some may be eligible for surgery, certain conditions may be eligible for brachytherapy or something else. And so, but if you are delivering a treatment, and if the treatment is working or not, so need some other additional ways. And just because of the place of a prostate is very difficult to do that kind of job. So one of the earlier works that we did was we were trying to just use light to see if we can do this. And then I came from two groups, my PhD group in Connecticut, and then my postdoc group in Dartmouth College. They were all working on using light to help detect or diagnose breast cancer. So when I started my lab, I thought I want to deal with this prostate. But the approach and we know how this light works. So basically, if you shine light into the tissue and our tissue scatters, and then so we will be able to detect at somewhere else, and then this is non-radiating at all, so you can very non-invasive. And then if there's something happening down there, the signal will change, and this might be a cancer tissue, might be something else. And then also if we can put in multiple wavelengths to address the spectral contrast of certain things happening with cancer, maybe a more or less oxygenated, or maybe angiogenesis, maybe something else. And then the signal will also change. And then by using all those information, we will try to know what's happening below the tissue. But if we are interested in imaging, you are not going to be able to do this by just shining light at one place and detecting light at one position. You won't be able to do it because you are detecting a bulk tissue. Then you will have to introduce a lot of channels to getting light into that, and a lot of channels to detect light out of that. And then with that, you might then need a mathematical model. In some cases, they are much more complicated than X-ray tomography, and to recover what's happening in the tissue. So this was some earlier work we did. So basically, because we're dealing with prostate, so the standard approach of imaging prostate, and for prostate biopsy or for other treatment monitoring, we have to use transrectal ultrasound. So we were able to implement this 9 channels of optical source, excuse me, 9 channels of optical detector, and at least three wavelengths, and then to put into over here, and then so we try to image over this sagittal plane and try to image some optical contrast that prostate, the cancer, when it develops, it might be able to show up. So, and then you can see that we have a transrectal ultrasound, and then we have a pretty complicated system of so-called transrectal diffuse optical tomography. And you can see some kind of illustration. So this was a transrectal ultrasound of a prostate area, and this was a transrectal optical tomography. And this was completely non-invasive. And the only thing is that we're going to need to have a transrectal optical probe, so built into that and then place. And so since this work was very challenging, we were only able to do it in the dog models. Excuse me. And we did a number of studies, and one of the interesting work we did was we were able to identify where it was very hot, and then when the tumor kind of regresses, which usually don't happen in the human cases, but it's similar to when the treatment works, and then when tumor regresses, and then we could see optical signatures of that, which was not very clear on ultrasound, or was basically unremarkable on ultrasound. So this works we did, actually we will help us understand that there are actually some substantial information that even just pure light can tell. And after our work, and there are actually, in addition to our work, there are other groups who have continued along this line with different ideas, but I'm not talking about the photoacoustic. I'm talking about just using the optical tomography, okay, and light absorption, light scattering. I just want to introduce a few groups of work. They may not be exclusive, but here I feel like Professor Andrews Hischer, who used to be in Columbia University, now is in New York University as a biomedical engineering department chair. And they have developed transrectal ultrasound probe and for optical tomography. It's essentially their approach from the mathematical perspective. And also the Professor Han-Li Liu in University of Texas, Arlington, they have had the studies on try to understand how to recover the resolve of the prostate cancer foci better by using this technique. And I just want to emphasize that this technique is extremely dependent on mathematical reconstruction. So the math part is slow. It will be much faster now with all the new techniques of accelerating computation, but it's a pretty big challenge on the image reconstruction. And also, I also want to mention the Professor Brian Wilson's group in University of Toronto. We have collaborated on one project, and they are actually using this transrectal optical tomography to monitor the tissue property changes during the laser focal treatment of prostate, the primary foci. And I know there are also other groups in Europe. They are also carrying along this line of the work. But I would say that there are a lot of certainly a lot of potentials, because if you can implement optical channels into transrectal ultrasound, and then it's completely non-invasive, and then you can just follow the regular transrectal ultrasound protocol, and then if you can get image that adds another optical contrast to acoustic the images, and then you probably have a better chance to identify where is the hot spot, so you reduce the number of biopsies. And also, if this can be combined with maybe MRI and or some other techniques, you might be able to monitor the progress or how the treatment works. So there are great potentials over here, and I hope that this work can be continued and can be paid attention from academia and the industry. But the challenges are there, and you can see not very many groups are working on that. One major challenge is how to develop that transrectal probe, which is enormously challenging. And you can see that this is where the probe needs to be like that. In the rectum, at least you need to have multiple channels, try to image the other way and the side way, sagittal way or coronal way, it's the other way, and then it's a very tight space. And we managed to fabricate our probes onto this is a veterinary the transrectal probe. It's about the same size as a human probe. So, but the challenge is how to build that many optical channels over there and in that tight space. So that was really, really interesting work. And I just want to show you that was a probe had 16 optical channels, and built into that. That was the very first probe my lab developed. And we did some imaging from a healthy canine dogs. But because of this work, I was given this cartoon, and then so sometimes you might be able to find me a cowboy holding a probe like that. Okay, but anyway, so this was the work that my group did, and then there are pitfalls, there are potentials, but I still think this is a great direction that to be carried over. And then in case you have noticed of those works, and I love to learn about light, and I love to use light to do something useful. And thank you very much. And that's what I have. Thank you very much.
Thank you so much, Dachin. This is actually very good. There is so many questions like popping out in my mind, like, you know, what is the deep, how you can implement it, so these kind of things. But before that, please let's go to Jonathan. So Jonathan, have a question for you. Please, Jonathan, open your mic and ask yourself.
Sure. Thanks, Dacheng. That was a great talk. It seems like, yeah, photoacoustics could have some great advantages over ultrasound for guiding biopsies. Is that something you've looked into, the ability to guide the biopsy procedure for the urologist using photoacoustics? And I guess related to that is, can you deploy a biopsy device while your transrectal probe is there? Does it allow for the biopsy to still be performed?
Okay, and Jonathan, Dr. Liu, thank you very much for your question. And then actually the photoacoustic side of the approach to address prostate biopsy, it's my student Gary Xu, and then he is taking on that direction. So my lab, I have always focused only using diffuse optical tomography. So I did not venture further into that. So I believe that photoacoustic will be able to add some information that certainly because of laser-induced that contrast, and will make the contrast much better or much more specific potentially, and which I will hope that my student and his collaboration in Michigan, they will be able to answer. And actually we had collaborators come over to use our dog model. We have done a very one photoacoustic the imaging of the prostate cancer developed in dog model. And it's a very interesting one. I see there is a different potential there, and I would really encourage going along that direction. And but to gain the optical spectral contrast as diffuse optical tomography can do in multiple wavelengths, and then that might be a challenge for photoacoustic. You have to generate the contrast from multiple wavelengths that gives the spectral information that you might need. Otherwise, it's anything absorbing light, particularly. And also another one is that prostate cancer, even the hot one usually is not very angiogenic, so that light absorption contrast may not be very high per se for the photoacoustic approach. So in that sense, every approach might have limitations. So that's what my take is. Thank you very much.
Thank you.
Right. Thank you so much. We have a question here from Michaela. And Michaela, I understand you also have one slide to share about your work at Pioneers. Why don't you ask the question and share your slide and let us what you do? Let us know what you do.
Yeah, of course. Thank you for your talk, Professor Piao. So what I was very interested in your talk, since we also like work in diffuse optics, and I was wondering whether you are using laser diodes for shining lights or LEDs. And so I'm assuming you're using broadband continuous wave light source. And related to that, have you tried also to retrieve some information about the concentration of chromophores, which you are looking at during the diagnostic process?
Thank you very much for your question. It's actually a very important question. And when during that phase of the work, we used the light from 4 laser diodes, and they deliver probably about 10 to 20 watts of power. And the one thing is that LED probably won't work for transrectal optical tomography of our work, because you're talking about shining light through the rectum and then going the other way. So there are a lot of the light loss over there. So it was necessary to use the laser diode, as even for optical tomography of breast we apply. And in terms of the chromophores, actually one of the studies we did with multiple 3 or 4 wavelengths, we were able to actually identify the changes of total hemoglobin from a very aggressively developed prostate tumor in the dog model. We could see that change, the change, and which yes, so there is a great potential to do that. So I think there is no question that diffuse optical tomography, if you put into the right number of wavelengths and to identify the chromophore, if you are only talking about the hemoglobin, and that it can be resolved. And if you add more wavelengths, like people have done in breast, you might be able to resolve some other maybe lipid or water changes, something. Yes. So I would say that all the technical and all the clinical results obtained by diffuse optical tomography applying to breast, there are potentials to translate to prostate. But again, the key question is, can we develop the transrectal probe to make it work? And that was the major challenge. Thank you.
Can I ask you if related to the transrectal probe, were you trying to develop it in-house, or did you try to make some companies work to develop the actual probe itself? Because we're finding the same challenges, because it's something very hard for clinical practice and clinical application. So I'm very interested in your experience.
Thank you very much. I'm proud to say that all the transrectal probes we use, I developed in-house with my own hands in our machine shop with under microscope. That was all my output. So
that's amazing. That's amazing.
Yeah. So it was really, really challenging. And now my eyesights are getting worse. I don't know if I could redo it again, but the experience we had, all the modules to develop, to build the probe, how to combine that with the transrectal ultrasound. And so those parts, hopefully it can be useful to, if we are not continuing on that part, hopefully we can continue, but if some other people are interested, and then I will be happy to share the knowledge. And some particularly that the long transrectal probe, I still put in my lab to just entertain visitors. But some other probes might have already been basically disassembled, but that probe is going to be there until I retire. Thank you.
Thank you very much for your feedbacks. And yes, I think it's a great opportunity to kick in and tell you a bit about Pioneers, because we are working pretty much basing our measurements on the same basics that Professor Piao just explained. So let me share my screen. Share. Okay, can you see it?
Yes.
Okay. I'm CTO at Pioneers, and what we are trying to develop and commercialize is the next innovation in diffuse optics. And we base our technology in what is called time domain near infrared spectroscopy. So I also share a lot of technicalities with previous colleagues that presented, talking about single photon countings and time correlated single photon detection. And so why is this interesting for tumors? So what our main ability is to retrieve information about oxygen concentration. So both tissue saturation and total hemoglobin. So based on the technology that we use, it is possible to retrieve absolute information on the measurements, so to be quantitative. And this leads us to retrieve important information related to oxygenation of tumor regions. Of course, we have to be able to reach them because penetration depth is around 2.5 centimeters, not more. So only superficial tumors can be detected, or in case of transrectal application, for example, this could be a killing application because the penetration depth could be well enough to characterize those kind of tumors. So with those measurements, we are able to detect, for example, tumor hypoxia. We have indexes about the chaotic vascular networks that can be formed inside tumors, and we have also information about vascular impairments in the regional part that we are measuring. So despite what has been said from Professor Piao, we are not making tomography with our devices because they are single channel. So we place the probe in the region of interest, and we retrieve numbers from that measurements. So this is the this is the device, like the off-the-shelf device that we have, and it's called the Nears box device. And we tried our best to make it as plug-and-play as possible and suitable for clinical usage. So this is used for regional tissue oximetry, and it can be very interesting for application into tumor characterization and monitoring, for example, during treatment or diagnosis. And so behind time domain Nears, so despite continuous wave Nears or intensity-based technologies, we used very short laser pulses, which are injected into the tissue and collected some centimeters apart. So very similar to the application of Dr. Piao. We are able to retrieve then with single photon counting, with time-correlated single photon counting, the pulse of the lasers, and thanks to the modification of the pulse in time, we are able to retrieve absorption and scattering coefficients. And those two numbers are separate to each other, so we disentangle their properties. And this enables us to have very high accuracy, reproducibility of measurements, stability, and the possibility of being quantitative. Main applications are on the brain and brain monitoring, but a very high potential is found in tumors application and cancer tissues. So other than oxygenated and deoxygenated hemoglobin and the volume of hemoglobin in the region, by changing our wavelengths and adding more wavelengths into our device, we are able to retrieve also other concentration of different chromophores, such as water, lipid, and collagen, which, for example, in breast tumors and breast cancer tissues are paramount. Here you see an example of reconstructed images of with different wavelengths on a breast with some tumor lesions. And so going multi-wavelength, this is another device which we developed related to diffuse spectroscopy in general, always based on time domain near-infrared spectroscopy. And this enables us to retrieve information about lipid content, collagen, and water in the region that we are measuring. So as an example here, some striking applications have been developed in European-funded research projects, such as thyroid nodules characterization in the LUCA project, and other application related to the Solus project, which ended a couple of years ago, which is based on time domain Nears with different wavelengths and used to characterize breast cancer tissues in women. And here is an example of image reconstruction of the lesion with information about blood, water, lipid, and collagen concentration. And with that, I'm closing it up and showing you a bit of our collaboration around the world. And we're mainly working in Europe, US, and Canada, and hoping to expand in the next years, and hoping to develop new technology and application in the clinical settings. So thank you. I'm open to any questions, and I'm open to see what you think about these kind of applications and possible collaborations.
Yeah, thank you so much, Michael. Actually, I mean, there are like a lot of things happening in ultrasound, but there are not only applications, as you say, that are translated to cancer. But for example, like when you have any infectious, so if you are going to high degrees of infection, so that also can help. I mean, there are so many applications, and this is actually very nice technique. But now it's time to move, because we continue talking about breast, and let's examine the breast. And for that, I want to invite my dear friend Anna Nikiel from Tele9. So she is the leading for strategy, and the technique that she is going to present, I really love it. It's going to be like very well also. Is more friendly with us, the women. So thank you so much for this disruptive technology somehow. So Anna, the floor is yours.
Thank you, Helena. So just allow me share the screen. Yes. Can you see my full screen now?
I don't know. Now. Okay, now it's good. Yes.
Okay, good. So my name is Anna Nikiel. I'm responsible for the breast cancer business in the Teledyne, and I'm located in the Netherlands. And today, indeed, I outline how the new technology from mostly imaging technology from the Teledyne is revolutionized breast cancer detection, which impact the millions of the women worldwide. And I know that you heard this statistic before, but I think we should hear them many times just to remember. So breast cancer is leading cancer among the women. 1 in 7 is affected. Every year, 2.2 million new cases are diagnosed, and incidence is rising, and it's happening especially in the developing country. So if you're looking for the Teledyne technology, and today will be a lot of technology, and we do a lot of stuff. So I just want to outline a little bit what we are doing. And if you have a specific question about some of the technology which I described today, let's stay in touch. So Teledyne is active across the entire patient journey, because we have a global presence, and we have a very solid know-how and IP. And we are also looking for the clinical application. So we are always start developing new technology with a clinical needs. And we are involved in the screening, and I will explain a little bit how this patient journey looks like. And if you have also more questions, I will be happy to answer. So now the screening start with a low dose, usually X-ray mammography, and we screen the women among between the 40 and 70. It's mainly happen in the US and in the Europe. And we are also responding to the international call for the pre-screening at younger ages. And the statistic and the data which we have showing that the cases are indeed rising in the developing country. And why we do this, I think that Jose mentioned this on the beginning, because early detection of the tumor is crucial. And we can, survival rates can really surpass 90% with a timely diagnosis. So regular screening play a vital role in the women's health. Now diagnostic starts when we observe some symptoms, and we again mostly use for the diagnosis mammography or tomosynthesis, which is more like a CT, I would say, mammography CT. And we are also present in the therapy, because Teledyne is producing the heart for the radiotherapy devices. And with our new technology, we have also advanced technology for the monitoring recovery of the patient at home. And if you're using for the core of our technology, it's always the CMOS and the different kind of the using detection of whole spectrum, electromagnetic spectrum. So we talk today about the light. I will talk a little, and we talk about X-ray. So our core business, and some of you already know this is the CMOS detectors. Why CMOS detectors? Because using the semiconductor physics, we can convert the X-ray to the electrical signals with obtaining low dose, high quality image. But also the patient and the habits of the patient are changing. And what Helena mentioned, that we are working on the more women-friendly technology. So we have we develop a new kind of the pressure detection platform during the mammography. We know that, and it's exciting and very nice to talk about the all exciting technology of the future. But mammography is the standard method for the diagnosis, for the screening, and it will be probably for the next at least 10 to 20 years. And what happened for the mammography? I think all women which have a mammography experience this. For the people who didn't have a mammography, to perform the mammography examination, first what you have to do, you have to compress the breast. And it could be extremely painful, especially for the women with a smaller breast. And if you look for the statistic, 20% of the women skip or postpone the mammography only due to the pain. So what happens normally when you compress the breast, the technician is looking for the force, right? And they usually get they read the force on the mammography system. There are no standardization of the force. It depends from the country to country. It depends from the technician to the technician. And we always laugh that Dutch are the master of the compression. To the point that more than 100,000 women last year wrote the petition to the government to do something with mammography examination and with compression because it's so extremely painful. So we, instead of looking for the force, we are looking for the pressure. And I think in the room are more scientists with the good physics backgrounds to know that the pressure is the force divided by the contact area. And thanks to this, we can really personalize compression from women to women, right? So the women with a smaller breast, and they get less force, and the women with a bigger breast, they get a little bit more force. And why this is important is not, of course, the comfort and working on the more female-centric solution is very important for us, but there are also another reason. So we know that the compression is a part of the mammography, but if you compress too much, then the blood is flowing away from the certain tumors, and you can miss some tumors. And if you don't compress enough, then you get the blurry image, and you have to repeat the mammography. So the right compression, and we are always aiming for the 10 kilopascal, which is the average pressure of our blood, is not only much more comfortable, but is also improving the workflow, because immediately technician and patient is looking, okay, I have to just stand a little bit more, and this is the right compression. So it's improving the workflow, but also the right compression improving the better detection of the small cancers. So that's the one portfolio. That's the products which we have in our portfolio. But we are always looking for the new technology which can make the detection of the cancer better, faster, and more precise. So we have also in one of the platform which we are working on, there are the ultrasounds technology. It's not based on the piezo, but it's on the based on the capacity measurement. So it's a CMUT. We also looking something what is very interesting is infrared dynamic imaging. And if you're looking for in the past, the thermography have pretty bad press, especially among the doctors and radiologists and surgeons. But over the last 5 years, what happened, we observed the tremendous improvement of the hardware and Teledyne FLIR camera, where you can really, change the range, not between 70 degrees plus 100 degrees, but you can really change it, the range to a couple of the degrees. But also the improvement and development of the AI, we see unbelievable results with the infrared imaging, which is a very nice tool for the pre-screening because it's relatively cheap, and this kind of the pre-screening device is already active in some of the developing countries like India. But also it could be used, and we observe very interesting results during the compression and release. Could be added as a multimodality to the mammography. I don't have time today to talk about about the breast density, which is another issue among the screening and among the women. But infrared imaging could be additional, very nice modality to detect a special kind of the cancer. And technology and I think theory behind the infrared imaging is that if you have a cancer, the blood is flowing to the vessels to the cancer. This place is much warmer, so we observe the unique pattern transmitted to the breast surface, which you can detect using in the sensitive infrared camera and special AI algorithm. We are also looking for the PET and SPECT technology, mostly from the point of view of the detectors. PET SPECT is only one modality which can really look for the metastasis. So we talk a little bit about the biology-guided biopsy now. So that's something also very interesting for the Teledyne and how we could use it for the breast cancer, but also maybe for the prostate cancer. And the last point which I want to mention today is the biomarker detection. And here we are working for all kinds of the biomarker detection in the breast. So we have like a measurement of the stiffness, which can very early indicate of the breast cancer. But we are also, as a Teledyne Healthcare, working pretty close with photonic integrated circles community, and we are working on the MEMS-based devices to measure all kinds of the biomarkers. For example, for the sepsis, very interesting project, but also another biomarkers from the blood. If I have, I don't know, Helena, if I use all my time, but I have very short video to show you a little bit about mammography and about the compression. It's just the first.
Very quickly.
Okay.
Thank you.
So I just want to show you guys if you could see how the mammography looks like. So normally what we do is a compression, and one of the technology which we bring, this is with a machine vision, with a visual light, we can really create independent solution from the mammography. We can, that's, as you can imagine, this is very painful. So we can very clearly see the comparison between the small breast and the big breast. And we always, as I mentioned, aim for the same pressure, but you see that the force is different. So thanks to this solution, we can make the mammography more efficient with better detection of the cancer, but also more women friendly. So that's all what I have today for you, and I'm happy to take a question and answer you.
Thank you so much, Anna. Thank you so much. I will connect anyone with the questions with you. But based on what we saw today, I would like to bring two people that are in the room to the conversation. One is Celia Milon from Raven, and another person that I would like to talk is is Mary Johnson from Wavelength Electronics. I know you have solutions that would be suitable as part of the supply chain for this. So Celia, why don't you tell us what you have? I know you have some exciting ultra-fast lasers that can be useful. Then after that, Mary, you can share how you can help Celia and the rest of the team.
Thank you. Hi, everyone, and thank you for giving me the opportunity to present Raven today. So Raven is a small startup. We are based in Germany, in Bochum. For those who know her, we are spinning out of the group of Professor Clara Serracello. And we are developing ultra-fast laser emitting at 2.1 micrometer. We propose two different products. The first one is an oscillator. You have the spec on the side. I will a bit short and not repeat everything. And the amplified version, Raven L. So why I'm speaking today? Because 2.1 micron is holmium-based laser, and they are already used widely in the medical field. They are used a lot for lithotripsy, but in the cancer field, they are also used for hypertract urothelial carcinoma, for a lot of gynecological also cancer. And how are they used currently? They are used using a photothermal effect. So basically, you just blast the cell. You increase the temperature up to 60 degrees, and you can easily imagine that to do such a photothermal effect, you need a joule level laser. So most of the lasers currently used are continuous laser or quasi-continuous. So why am I speaking about femtosecond laser now? Simply because there is a lot of paper showing that femtosecond laser could be more effective to treat those type of cancer using photochemical effects. So there is specifically one professor in Lübeck in Germany who has studied a lot femtosecond interaction with human tissue, and it shows that it could be used for cancer treatments. So my question for the audience today, or why would be interesting to get your input, is one, first of all, if you are familiar with those surgery or those type of treatments, you know if the femtosecond laser are currently used in a hospital for such a thing, or is it completely a research field still? And if yes, what would be the next step to bring that into a clinical procedure? That's it from my side.
Okay, and actually, in addition to Mary, we have Nathan in the room from Take 5. So Mary, why don't you all tell us how we can help Celia and the rest of the people that are in here, and Nathan, after that, you share what you do, and we'd like to learn more about you as well. Go ahead, Mary. The floor is all yours.
Thank you, Puya. I am Mary Johnson, founder and CEO of Wavelength Electronics, and I'm excited to be involved in such a discussion. For those of you who don't know Wavelength, we've been stabilizing laser diode wavelength, current, and power, and delivering low noise electronics for about 3 decades now. Our customers are brilliant. I'm impressed with all of the research I've heard today. The researchers we work with, the system developers we work with, the entrepreneurs, they have visions for how they would like to improve the world. And so we help with them with the electronic subsystems so that they're free to explore and invent. So we build OEM laser diode drivers and temperature controllers that have benchtop instrument performance. So we also offer touchscreen instruments for researchers and very low noise quantum cascade laser drivers for very narrow line widths. We couple all of this off-the-shelf electronics with high reliability manufacturing, so our field return rate is less than 0.1%. So very high reliability out in the field. Our equipment is very often used in medical systems, surgical devices, medical and biological detectors, cancer therapy. And I have just 2 case studies to briefly highlight today. One, using hypoxia, uses fluorometry to identify tumor aggressiveness. So we've already heard about some of those kinds of things. And in this case study, researchers from Spain used the fluorescent hypoxia biosensor to do the functional imaging of tumor cells to provide that critical information about size, location, and then the microenvironment. For that application, stable wavelength was absolutely critical, and they used our LFI temperature controller to achieve that goal. A second case study from researchers in the UK, they created a biolaser where a virus is introduced into the lasing cavity and used to detect the concentration of the viral load. They proved that rapid biomolecular detection could match the precision of already commercial available systems. So in that application, constant current, stable wavelength, modulation were critical parts of that system. And our WLD laser diode driver was used to achieve those results. Basically, wavelength, we are committed to customer success. In addition to our off-the-shelf components and instruments, we're offering custom engineering services to put exactly the right electronics in exactly the right fit that you might need. So if you use a laser diode, a QCL, a VCSEL, a SLED, any semiconductor laser diode, if you need low noise, if you need stable wavelength, stable power, stable current, I would love to chat with you. We'd love to be part of your team.
Thank you so much, Mary. And Mary is actually very popular. I've made connections to him, and she's had lots of requests for wavelength electronics. So that talks to the quality of the products that they have. Now, we have another speaker in the room, Nathan Stebbins from Take 5 USA. Nathan, I know that you have something to share with the group that is in here. Why don't you share your screen and let us know what you do?
Sure. Hey, thank you, everyone. So I'm with Tech 5 USA, and we make primarily online NIR, UV-Vis, and Raman spectrometer systems. And I'm actually a food scientist by trade, and so I work in the food industry, but also with pharmaceuticals, medical, even some chemical and oil applications as well. So talking about diagnostics today, in the US, breast and prostate are unfortunately some of the most popular cancers that are available. So it's about accurate diagnoses and making sure that those diagnoses can be done quickly and efficiently and accurately. So primarily due to cost and time are the issues for whether it's biopsy or blood sampling for current methodology. So looking at something faster, more readily available that could be done on site with less sample prep. And this is a couple of slides here talking about Raman spectroscopy to provide those faster, less invasive methods using blood and serum samples. Raman provides a nice spectral fingerprint that contains the information about the cell surface chemistry and using that for predictions and diagnoses, as I mentioned, for blood and serum, and using that in real-time Raman data. So you just spin the blood down, collect the serum, place that on a slide for measurement, and using a 532 nanometer Raman laser for measurement within just a few seconds. You get specific peaks there that align to whether it's specific lipid compounds, amides, even some of the collagen nucleic acids that can be detected there. And it's just a very simple sample preparation technique and diagnostics, again, within seconds. That was quick, but that's all I have to share for today.
Thank you so much, Nathan. And actually, I mean, TechFac has so many technologies applied for medical. It's not only for cancer, but it has also like a lot of neurodegenerative diseases, which is another subject that should consider some moment to have a big discourse about that. But this is very good. And talking about the spectroscopy, let me invite to the floor to Henrika Tainitin from Modulite, all the way from America to Finland. So Henrika, the floor is yours.
Thank you so much. And thank you, first of all, everyone, for the great, interesting discussion and great presentation. It's been a pleasure to listen all of this. I'll just quickly share my slides, just a second. Can you see my slides?
Yes.
So we at Modulite do, thank you. We at Modulite do lasers and optics for personalized medicine. In addition to these full clinical systems, we do these OEM subsystem products, for example, for imaging and flow cytometry. Our core is the customizability of our lasers from wavelengths from UV up to 2000 nanometers and power levels from milliwatt level to really the presentation today I have is focused on killing cancer by photodynamic therapy and photoimmunotherapy. So this is a market analysis by McKinsey, which really shows the high unmet need in several indications in the oncology sector. We at Modulite really aim to target these indications where the need is high. All of those marked in orange are the ones that we are very active in the field at the moment. The figures presented really show that a 95% figure means that only 5% of the patients actually survive 5 years after diagnosis. So there really is a need for finding new options for treatment. Just a short video.
The sound is not playing if the video has a sound.
Sorry, there's no sound?
There's no sound. I think when you shared the screen, you had to select the option for sharing the sound.
So
but you can talk. You can talk over it. That's fine.
Sure. So I'm so sorry. So basically, what the video is all about, it's presenting our full integrated factory. So it's fully vertically integrated, meaning we do everything from the small laser chip level to these whole subsystem products, full clinical solutions. We really provide all the services to go with, from regulatory services and also utilizing our biolab for validating full solution from used fiber optics to the actual platform, endoscopes, and much more. Well, this basically presents all we do. So our slogan is join us to kill cancer. We really see ourselves not only as a laser provider, but kind of like an all-in-one solution for oncology treatments. We have an extensive network of key opinion leaders. On the left, there's only a few institutions in which we actively work with. All our lasers are multi-indication platforms. So basically, one platform can be used for multiple different indications, from brain to breast to lung, you just name it. All can be customizable to everything made here in-house at our factory. As said, we provide all the clinical trial support, from on-site treatment support, training of the lasers, installations. We keep the fleet fully functional for years to come due to annual maintenances. We provide all regulatory support and very many different forms of service also for the commercial phase. All of this is supported by our PPT, pay per treatment business model, which really allows our customers global and indication expansion possibilities fast and efficient. A few words about the principle and procedure of photodynamic therapy and photoimmunotherapy for those who might not be that familiar with it. So basically how it works is there's the administration of the photosensitizing agent, for example, via IV, injection, even orally. The photosensitizer is then metabolically distributed in the body to the cancer cells. And there in the cancer cells, the laser activates the photosensitizer. So this is really a very precise targeted therapy, non-invasive, and it protects the healthy tissue from any kinds of side effects. And as the laser excites the photosensitizer, there are reactive oxygen species formed, which actually kill the cancerous cells. Our platforms are dual in nature, in the sense that we provide both detection of the cancerous cells via fluorescence and killing the cancerous cells with PDT and PIT. So here is to highlight what we do in the field of prostate and breast cancer. First and foremost, there is a comprehensive review on photodynamic therapy for cancer treatment, which was just published in Nature Reviews Bioengineering, co-authoring our CTO, Petteri Uusima. And there are a few research articles and application notes, which you can see here. For example, in Duke University, there's a lot of in vivo and in vitro research ongoing, utilizing our lasers for breast indications. Another example, for example, MSKCC, where there's a lot of in vitro research around prostate cancer using our lasers. So basically, due to the full customizability, the same product can be used all the way from preclinical in vitro, in vivo research to clinical therapies, all supported by our vast, extensive services. I think I'm soon running out of time, but please let me know if you have any questions, and we would love to connect also later on to discuss more.
Well, thank you so much. And I apologize because actually we were the one who ran out of time, but the discussion have been amazing. Have been really amazing. Henry, if you can stop sharing so I can share some slides. So it's a last information. All the questions that haven't been passed yet, so they are going to be passed to them. Whoever you want to connect, please feel free to do it. Elise, could you please share my slides? Yes, and thank you so much. I mean, it has been a great discussion. There is so many work to do, really so many work to do. So I want to thank you. Oh, no, yeah. Okay, yes. I want to thank you. So we have our main integrators and adopter. So we have been the Molecular Biophotonics Laboratory from University of Washington, Oklahoma State University, Teledyne and Moludite, and our enabler solutions have Photonics pioneers, Raven Tech, 5 USA and AlphaNov, which presentations you already saw. If you want to connect with them, please come back to us. This is all the people that have been registered. So this is basically the value and the distributor change. You have laser technology as R&D, transceivers, optics, quantum, sensing peaks. So you don't see yourself in here is because this is only the members that were registered for here. So if you want to show up in this value change, please join us, because this is the way to support us. We try to support you, but please support us. So join Optica. And next, please. Next slide. Yeah. Okay. So all the content here, this is available by YouTube, but all the content here is available at the Optica Online Industry Library, and everything that happened in our meetings is going to be there. There are also a collection of market reports. We have several on medical devices and and also in all kind of lasers, peaks, quantum sensing, all the things that we really need to complain, all the things that we haven't discussed here. After that, please next. Yeah, so join us for the next 27th of August, Tuesday. So it's going to be the online meeting in peak manufacturing and testing. That's going to be hosted by Jose Pozo and Puja Dianat. And thank you so much. Let me very, very, very thank you. So next, please. So if you want to get in contact with any of the participants today, please send an email to our CTO, Jose Pozo, or you can find also our emails in the chat. So we are Puja Dianat, Olga Raz, and Elena Diaz, and Jose Pozo. Thank you so much, everybody. See you next Tuesday.
Thank you, everyone.
Yeah. The credits. So thank you, everybody. So you don't need to drop if you don't want. Elisa, okay, the credits.